Because if it is affecting more than 5% of the RBC, there is a hypertherapeuria. The complications would be much serious and patient is likely to be fatal. Next. Good quality of microscopy is difficult to implement and maintain. Large amount of paper is needed. As the limitations of at the molecular level require highly skilled personnel and regular curriculum course. As I said, PS may be needed in patients with severe infections due to sequestrations and partial treatment. Patient must by the way, patient gets to you, he might have taken on his own or he might have been treated by somebody else, and we may not come to know that he has already taken a course of antimalarial drugs. He might be the infection of the microscope. So these are the patients which normally can be confirmed by rapid diagnostic test or a repeat microscopy. Next. What is rapid diagnostic test? The use of malaria RDT is recommended by WHO when the reliable microscopy is not available. But it is not the only substitute. We have to go for a microscopy first and we can confirm it with RDT if it is not confirmed on a simple microscopy. Many laboratories offering malaria diagnosis declare to use RDT as a tool for diagnosis. Most of the laboratories are using, and we are also asking most of the time for rapid tests. Rapid diagnosis is use is recommended if performed in conjunction with microscopy. Rapid diagnostic test shows percentages lower than 58% sensitivity in malarial concentration of less than 100 microns per liter. Next. Next. This is again a very major concern because world over nowadays we are finding most of the malaria drugs which are in use, we are finding resistant to most of the drugs. And chloroquine is one of the important which is showing a lot of resistance to the malaria. They have shown a distribution and scientific crisis they are showing where the maximum number of patients are seen and where the chloroquine is in use, but we are finding a lot of chloroquine resistance. Next. And these are the figures which are confirmed by WHO and drug control. As far as the resistance in plasmodium falciparum is concerned, resistance of falciparum to the commonly used antimalarial drugs, especially chloroquine, has been progressively reported in India. More than 80% of the therapeutic efficacy studies conducted from 2001 onwards till 2007, they indicate failure to chloroquine beyond the cutoff level of more than 10%. Next. Most of the time we find early treatment failure. Development of danger signs of severe malaria on day 1, 2 or 3 in the presence of parasitemia. Parasitemia on day 2 is higher than day 0. Again, irrespective of the absolute temperature, we have to see it as a drug failure or we have to keep in mind that in serious conditions we have to take appropriate measures. If we find parasitemia on day 3 with accelerated temperature more than 27.5% and hyperparasitemia on day 3 more than 25% of the count on day 0, we have to treat these patients vigorously. Next. Similarly, there is a late clinical failure in patients who did not previously meet any of the criteria of early treatment failure, development of danger signs of severe malaria in the presence of parasitemia on any day between day 4 and day 28, and the presence of parasitemia on any day between day 4 and day 28 with accurate temperature of more than 37.5%. We have to again reinvestigate, and if need arises, we have to again start with a fresh course of antimalarial drugs to these patients. Next. This is a resistance which is found in plasmodium falciparum malaria. Among the different drugs which we are using, chloroquine tops the list with almost more than 80% resistance in treating against the plasmodium falciparum malaria. Chloroquine, along with sulfadoxime and pyrimethamine combination, is almost to the tune of more than 40%. Quinine alone is showing treatment failure of 50.8%, and all the three drugs combined cumulatively, still we see about 5.7% of treatment failure against particular malaria. Next. This is the again a percentage of failure which is found in different countries in Southeast Asian countries. Next. This is again the area-wise studies of sulfadoxine with pyrimethamine efficacy between 1978. It's a long period from 1978 to 2007. And among the different regions like Arunachal Pradesh, Assam, and the percentage of total failure among the Indian patients from 1992 onwards, the percentage of failure, if you look from the beginning, it is increasing year-wise. Next. This is about the West Bengal, Madhya Pradesh, Odisha. The percentage of failure is total failure amount of in Madhya Pradesh is 42%. In West Bengal, in the different regions, almost 35% in 2005 and different areas. We did not go into details for this. Next. Amongst the important drug which normally we use is quinine resistance. Resistance to quinine is also there. Resistance to quinine therapy has been noticed sporadically in Southeast Asia and Western Oceania countries. In India, resistance has been reported to quinine in northeastern states and polar districts in Karnataka. It has been observed in northeast and southern parts of India also. A case of quinine resistance is being reported from Punjab. It's isolated from the Punjab. Next. Next. This is again a very important manifestation because the pregnant women are more susceptible, particularly to Plasmodium falciparum, and that can lead to serious complications of pregnancy, and they can lead to premature delivery or premature death and no birth weight. Pregnant women constitutes an important risk group for malaria infection. Effectiveness of placental barrier, parasite sequestration is placenta, can lead to malnutrition of the fetus, can lead to congenital malaria, and they can manifest as a cerebral malaria. With severe anemia, intrauterine growth retardation, as I have already told, it can lead to a low birth weight, premature interruption of the pregnancy. In fact, large number of infant mortality and maternal death are found with pregnant women who are infected with Plasmodium falciparum. As has been narrated, during pregnancy, it's a serious burden with many effects in the form of anemia, cerebral deficiency, again repeated. Next. The pregnant woman suffers significantly more from both Plasmodium vivax as well as Plasmodium falciparum malaria than non-pregnant women. The weight of neonates born to infected mothers was 300 to 350 grams less on an average than neonates born to non-infected mothers. The weight continued to be significantly lower until 6 months, affecting the growth of baby in infants. Next. The pregnant women with Plasmodium falciparum malaria were significantly more anemic than those suffering from virus infection. Of the 244 pregnant women who had falciparum infection, 3 died, whereas in another 3 abortions were recorded and 2 others had stillbirths. Only 1 stillbirth and abortion each were recorded in Plasmodium vivax infected women who were pregnant. Naturally, the infection presentation in the Plasmodium falciparum is more among the pregnant women. Next. complicated malaria. Normally we categorize malarial infection with uncomplicated or simple malaria. They present with a classical triad. We read them, we investigate, and they normally get clear without showing any complications. But most of the falciparum infections, they show lot many complications because of organ involvement, because of the number of RBCs which are involved. They are very high characteristic inflammation. They lead to a rupture of blood vessels and leading to many organ failures and leading to fatal complications. These are the percentage only which has been shown from the different areas. Among the southern states to Odisha, right from 7.9% to 30% mortality in complicated falciparum malaria. Okay. The patients with complicated malaria showing acute renal failure and death without renal. The blue slide is showing the number of cases of acute renal failure in common among the infected persons, which has gone up. If you look at the 1995 to 1997 series from comparing the 2002 series. Next. As some of the complications of malaria, because there is a multi-organ dysfunction, they need to failure. They show about 10.9% patients they are only the 10.9% without complications. About 43.5 complications are about cerebral, involving cerebral part, renal, hepatic involvement. 33% of the cerebral malaria is either renal or hepatic involvement, and about 11.7% constitutes the multi-organ involvement. Next. This is a study of plasmodium vivax malaria taken from a hospital in Bikaner. Showing among the vivax infections, the multiple complications in the form of almost 48%. Hemoglobinuria 4.2, pulmonary edema 4.2, shock due to pulmonary failure 6.9%, abdominal bleeding 8.3%, cerebral dysfunction with multiple convulsions 8.6%, respiratory distress with metabolic acidosis 11.1, and severe anemia 15.3, and jaundice constitutes almost 45% of the population. Next. Again, we are looking at the high malarial states, Odisha, Jharkhand, and Chhattisgarh, where the proportion of mortality from 1 month to 69 years attributed to malaria is found highest among these states. Again, it's a statistical data. India has 15 million cases of malaria in 19,500 to 20,000 deaths per year, versus 2 million cases and 1,000 deaths reported. The actual figures they have graphically depicted. Among the population in malaria areas from 1997 to 2001, the percentage of estimated cases and reported deaths among the area. Coming to the malaria management. Next slide. As per the guidelines, next for the treatment of malaria, the objective of treatment in uncomplicated malaria would be to cure the infection, to prevent the progression of severe disease, and to reduce the relapse of recurrence. Next. Among the drugs still are in use, the first line of treatment we always continue with the chloroquine. It is a still effective drug against plasmodium vivax because of its anti-inflammatory effect. And as far as the GI tolerability is concerned, we have to be careful because it may lead to gastritis, and we have to ask the patients to have it mostly, or patient can have something to eat and then normally we don't allow to take malaria on every stomach. The dose of 25 milligram of chloroquine is given as a base drug per kilogram over 3 days. Next. Primerquine is normally, because the plasmodium virus normally we see many of the patients with relapses, we have to prevent that relapse. We start with the primerquine, diagnose cases of virus, we follow up the chloroquine complete course with the primerquine, 14-day treatment of 0.25 milligram per kg or 50 milligram kg. Higher dose of 0.5 milligram per kg areas like Oceania and Southeast Asia, normally especially in Indonesian countries. If on investigation we find that candidate is B6 deficient or if the suspected, we can convert it to 0.75 milligram per kilogram on a weekly dosage for 8 weeks. But that is with cost. Next. If we find that patients are resistant to chloroquine and they are virus malaria, we can treat them with artemisinin-based combinations with LACDs and quinine combinations. Next. If the patient is infected with a patient is positive for plasmodium falciparum malaria, why we need to look at the patient differently? Because of high degree of parasitemia, there is a rotating picture because of cytoadherence, because of many of the complications with a common falciparum malaria, because they can deteriorate very rapidly, because there is a risk of having multi-organ involvement, because of the high degree of morbidity, and because of the resistance to many of the drugs. Because normally these days, even with artemisinin resistance is also started coming up. So we have to be very careful. Next. They found the first line of drugs, artemisinin combination therapies. Normally we combine because of the different modes of action. Dual interdependent action, rapid clearance of parasites. There is a long-lasting action due to the partner drug. There is a base risk of resistance. It's a well-established evidence even in children can safely use because of their excellent tolerability. And there are guidelines, recommendations from WHO, National Vector-Borne Disease Platform, and IIT. Next. As we normally use a combination of artemisinin and lubricant among the age group of 14 years and above, if your body weight is more than 35 kg, give artemisinin and lubricant combination of one tablet, one BID for 3 days in 2 long weeks. It's a complete therapy. Next. Because of its excellent efficacy, it is well tolerated. Lubricant because of its less resistance, and it has been recognized by US FDA. Next. The use of lubricant and combination among the 812 children with uncomplicated falciparum malaria. This is the constitution of children from 140 children, they are about between 5 to 8 kg. And treatment was with artemisinin and lubricant, and it was found with about a 97% efficacy. Next. This is the dosage schedule for artemisinin plus sulfadoxine and pyrimethamine combination. Artemisinin is 50 mg and sulfadoxine pyrimethamine is 525 mg combination. Among the children more than 14 years of age, we treat them with 3 days combination therapy. On the day 1, 2 and 3, we treat with artemisinin 50 mg and that is a total dose of 200 mg. That is a 25 mg 4 tablets. Along with on the day 1, we use sulfadoxine and pyrimethamine combination dose of 1575 mg 3 tablets of sulfadoxine and pyrimethamine combination. Serious cutaneous reactions following single single dose treatment with sulfadoxiflozin is very rare. Next, when we combine artesunate with metformin, we treat with this is the A1, A2 and A3. We start with artesunate 200 mg and valproate 500 mg daily for 3 days. Next. Normally, artificial combination therapy is in practice for harmonic transfer malaria. Those who are virus resistant to chloroquine or other drugs in mixed malaria infection, normally the choice of drug is artificial combination. In pregnant ladies, artificial combination is only used, safely can be used in second and third trimester. It is not advisable to use artificial combination in the first trimester. And it is good to switch over from IV to oral because very handy. Next, the alternative combinations which are normally used in cellular rates of ACT at the day 14. If we find a resistance to quinine or artesunate combination, the other drugs which are commonly used are doxycycline, gentamicin and tetracycline. Next, primarily in falciparum. Earlier we never used to give primarily to patients with plasmodium falciparum. Nowadays, in established falciparum, we use a single dose of 0.75 mg per kg or a state dose of 45 mg of primarily, which helps in increasing the transmission. Next. Normally used intramuscular activities are alpha beta artificial we use for the therapy in the form of injection 1 and 1. Artificial is inactivate patient and is for 7 years. The objectives of treatment for complicated malaria, because as I said, if it is neglected or it is not properly treated, it leads to serious complications and can lead to death. The objective is to prevent death, prevention of neurological death, and to have a complete cure. It becomes a medical emergency. Next. These are the manifestations of serial malaria complications. Patients of cerebral malaria, the management has to be directed to maintain airway-based patient on its further side. Exclude other critical causes of coma, for example, hypoglycemia from other causes as a differential diagnosis we had seen in bacterial meningitis. Try to avoid harmful auxiliary treatment such as steroids, they have no use. Heparin and adrenaline intubation if necessary. Hyperpyrexia administer tepid sponging, planning and cooling blankets if available, and antibiotic drugs. Paracetamol is the preferred drug of choice. If patient is having convulsions, maintain airway treat possibly with intravenous or rectal diazepam or intramuscular granulate, and keep on checking the blood sugar levels. Correct the hypoglycemia and maintain with glucose containing infusions. If patient is severely anemic, transfusion treat fresh whole blood. If patient is showing a sign of acute pulmonary edema, we make the patient prop up at an angle of 45 degrees, give oxygen therapy, give a diuretic, stop intravenous fluids to overload, intubate and a positive peak pressure is given in life-threatening hypoxemia. If patient is showing signs of acute renal failure, exclude pre-renal causes, check the fluid balance and increase sodium. If it is established renal failure, add hemofiltration or hemodialysis is of importance. Or if it is unavailable, it is more for hemodialysis. If patient is showing spontaneous bleeding or with the disturbance in coagulopathy, transfuse with clean fresh whole blood. You can use cryoprecipitate fresh FPP, platelet infusion if available, and give vitamin K injection. The patient is in shock. Also suspect septicemia, take blood from ulcer and leave blood not satisfied. Next. This time in the showing the use of articulate to clinic. Every 21 children treated for severe malaria with articulate rather than clinic. One life expectancy. Next. The drug of choice for malaria in pregnancy is a most silencer is mainly chloroquine. Meaning plus clindamycin to be given for 7 days and during the second and third trimester again. Apart from chloroquine, artificial combination therapy can be said. Next. As far as the prevention part is concerned, source of prevention of acne by DDT spray, antilarval measures, personal protection by using mosquito repellent, by covering yourself, and insecticide treatment beds. The drugs which are available to treat and prevent malaria, the micropene, doxycycline, and chloroquine on the weekly basis. As far as the vaccine is concerned, because still a malaria vaccine for the human use has not been found yet. It is still in the stage 3 clinical trial, and there are a lot of work is going on because by all these measures we are not able to prevent malaria. We need definitely a vaccine to have a complete eradication. Hopefully by 2015, because after the completion of the stage 3 clinical trials, we will be able to have hopefully a vaccine against malaria. Thank you very much. That's all. Classical triad normally, because in class, if you look at the classical presentation of the malaria, the classical testing groups last for about 6 to 10 hours. The first sign of cold stage of cold, and there is only a shivering and all these things. Because then again a stage of hotness, where we start having headache and all these things. Normally, they in the tertian malaria infections to be in every other day. Presentation of fever and all these things on the second day. Quarter malaria normally is the third day. But because of mixed infection, because of being partly treated, partly being, it is more on a clinical assumption, clinical presentation, and the classical history is partly being elicited by the patient. But most of the patients were able to pick up. It has to be constituted, reminded with the investigation. Mostly what we see normally again, we send the patient blood smear for malaria parasite. Most of the patients we see negative. If you look at from the patient's point of view that malaria is negative, then the malaria will again you are still at